Hello, in this session we're going to talk a little bit about what you need to know about the evidence base and a little overview of exercise to prevent falls and why it's important to you as a PSI. First of all, you may well be delivering many other forms of exercise, Zumba, body pump, flexercise, all sorts of kettlebells, and all of these are really very different to FaME and the delivery of a PSI. So if you consider that nowadays there's an awful lot of discussion about exercise is medicine, when you're dealing with exercise to prevent falls, you should treat it like you do a drug. So, for example, if you're going to take aspirin to prevent a stroke, you don't go, oh, I'll just give half the dose and only for a week. You know you have to do it for life. You have to take the right dose and you have to take it consistently. So, in that way, PSI is different to any other exercise program you've probably been on. It is an evidence-based program, there's a lot of research behind it, and delivered with the correct fidelity, in other words, doing all the correct things that are needed as part of the FaME program, you can make a big difference to people's lives. If you can reduce someone's risk of falls, make them more confident, they go out more, they're more socially engaged, and that's very different to an exercise program that people will just come along to, they're not worried about coming to, they're not worried about getting there. So working with fallers is a very different population group, and it's important that you have the ability to defend the delivery of your future PSI classes, that you know what are the key fidelity points and what is the evidence base behind it. And this is unfortunately more and more important as funders try and condense the time period at which it's delivered, put more and more people into classes, and eventually they stop becoming an evidence-based program and just become a free-for-all exercise program. Now, whilst we know that all exercise is good for us, if we want to prevent falls, we have to follow the evidence base. So that's what this session is about. So as a PSI, it is important that you keep up to date with research. You have to be able to defend your product. You need to know what does make good research, because there's plenty out there that isn't. Many programs do an evaluation, for example, but that's not robust research, and I'll talk a bit about that. How might you keep up to date? And essentially, what's the most important bits of research that you need to know as a PSI? So during this session, we're going to cover a variety of things. What is a systematic review? What's a Cochrane review? Because you will hear about those throughout the course, and more importantly, you can use these to defend your delivery in future. And then we'll talk a little bit about the large randomised controlled trials that form the evidence base for FaME. The first one being the FaME programme back in the early 1990s, a little bit about the Otago programme, which you've probably heard about, PROACT, which was a FaME and Otago randomised controlled trial, and then more recently an implementation study on the use of FaME and how commissioners can work most effectively with the programme. So these are your learning outcomes. Hopefully by the end of this session you'll have a little bit more of an idea about how to keep updated with research, understand the differences between research trials and systematic reviews, know the difference between primary and secondary prevention of falls, define the rate and risk of falls because different research programmes present data differently, describe the difference between a single intervention and multifactorial or multi-component interventions, understand a little bit more about return on investment and what that really means to your commissioners or funders, and finally, and probably more importantly, understand a bit more about FaME itself, who it works for and how it works. So first of all, how can you keep up to date? Well, we're not expecting you to go into lots of libraries, pick up lots of journals and spend a lot of time doing this. We put all the most important stuff up on the website under the PSI evidence-based resources. You can find a lot of this on the Facebook site, on the Twitter account, or of course you can come on our CPD days. We also put up a lot of information on synthesis documents which are drawing out the most important research and evidence base from Public Health England, Centre for Ageing Better, Age UK, ROSPA and professional journals. So essentially the best way to keep up to date is to keep in contact with LLT, keep an eye on our various social media accounts and on the website. So first of all, what's a research trial? The main thing to remember about research and research trials is they are meant to be unbiased. And the way they do that is they randomly put people into different groups, a control group, which isn't receiving an intervention or is receiving just usual care, and randomly perhaps into an intervention group. And it's done randomly because then you can't pick or choose the people that go into those groups. In other words, you could choose to put the ones that you think are more likely to adhere to a programme. Normally they're much bigger. It varies. So the biggest randomised control trial of falls prevention studies has got 9,000 people in it, and they go down to as small as about 100. So essentially they're not taking 3 or 4 people or 10 people and showing that they've improved. They're doing much larger numbers, and the people are randomly put into the groups. This means less bias, because certainly if someone's doing an evaluation of a programme locally, they might decide that Agnes, who doesn't turn up most weeks because she's got so many other things on, that they won't put her data in because she didn't really come that often and therefore probably didn't make a big difference to the intervention, so we just won't put her in. So randomised controlled trials don't do that. Everybody's data gets included. There's usually a long follow-up with multiple outcomes. So to follow up on falls, it's not easy. You've got to get people to keep diaries regularly, weekly, if not monthly. You've got to make sure that they complete them. You've got to make sure that you check whether the fall was a fall or whether it was a trip, whether they ended up in hospital, for example. And so all of these things obviously vary in terms of what studies outcomes you're interested in. And they're normally analysed on an intention to treat basis. This is whether or not they do the intervention, and is essentially how drug treatments are analysed. Okay, so systematic reviews are quite different from randomised control trials. This is where they take multiple randomised control trials with similar interventions and similar population groups, and they add together all of the outcome data. So this means that if you've got, 7 or 8 trials with 100 odd people, and you're not 100% sure whether they were powered to actually show a change, if you put all those trials together, you've got 700 or 800 people, and then you have better statistical outcomes. So essentially, some some systematic reviews only include randomised control trials, and the gold standard of that would be the Cochrane review, which I'm going to present a couple in a minute. And other systematic reviews do a wider look at the research. They might include case studies, that's individual people's changes over time. They might include observational studies, so not randomised control trials, but just following a group over time and seeing what happens. That's essentially an evaluation study that you would get on a local authority programme. But generally these conclusions are less robust because they have some bias in them. An example of a systematic review is the Physical Activity Guidelines for Health that the Chief Medical Officers issued in 2011. And so we all know these. The older adults should aim to do 150 minutes of moderate intensity activity. They should aim to do strength or balance training twice a week, and they should minimise the amount of time they spend sitting. And those very simple statements come from a very big big systematic review of all the evidence base with hundreds of research studies involved in those statements. So this is an evidence-based statement or guideline based on randomised control trials and large data sets. Interestingly, different studies that work with falls work with different outcomes on falls. So essentially, you can have someone that just falls very occasionally. Perhaps they don't move very much. They might be fairly frail, but they don't actually expose themselves to much risk, so they're an infrequent faller. Or you might have a recurrent faller that trips over everything and is constantly on the floor. And these people actually respond quite differently to different forms of exercise. But more importantly, there's very often different reasons for their falls. Essentially, if a research study presents a change in the rate of falls, that's the number of falls that each individual has. They're all then put together in a big pot, and you potentially can show that the rate of falls in that group of individuals reduces over time. So often interventions that work on rate, so the number of falls somebody has, are in the frailer, older, or the more frequently falling people. And essentially, we're talking about secondary prevention here. So they're already a faller, they're perhaps getting quite frail, and your intervention is aiming at reducing the number of falls that they have so that they're less likely to have a bad outcome, such as a fracture. Other studies present on risk. This is the number of people in that group that have one or more falls during the intervention or during the follow-up after the intervention. So it's the number of fallers. And generally, interventions that target those who fall infrequently, who perhaps are just sedentary and older, they tend to work better on risk. In other words, an intervention will just reduce the number of people that have a fall in the follow-up period, and they're generally used for primary prevention. Now, essentially what we mean here is you could have someone who's very, very frail, falling 10 times a year, and actually if you reduce their rate to 2 a year, for example, you vastly reduce their chance of them having a really injurious fall. On the other hand, you might have someone that very infrequently falls, perhaps maximum once a year, perhaps when they're rambling, but it's not they're not a frequent faller. And essentially what you're trying to do is ensure they don't become one. And therefore you want to ensure that the intervention reduces their risk of becoming a faller in the future. And interventions that target primary prevention are things such as Tai Chi, dance, and those sorts of activities where essentially you're improving strength and balance to such an extent the person doesn't become a faller in the first place. Those interventions don't tend to work with the frailer older adults, and that's where we'll move more into the difference between primary and secondary prevention and the evidence base. But first of all, I just want to introduce you to a couple of Cochrane reviews. If you remember earlier, I mentioned these are systematic reviews of large numbers of studies where they collate all the information together, and then they're able to tell you with more robustness that a particular intervention style works or not. If you look on the left-hand side of this slide, you can see that this particular Cochrane review involved 62 different randomised controlled trials with nearly 20,000 people in. So we're pretty robust results here. The multifactorial interventions are essentially ones where the person has a multidisciplinary review of their risk factors. So it could be looking at medications, it could be looking at eyesight, it could be looking at feet, it could be looking at continence, they could also be looking at strength and balance, they could be looking at neurological health problems, and the intervention is based entirely on that individual's risk. So not everybody will receive the same intervention. If you look at all multifactorial interventions in the literature, 62 research trials, we see some reduction in the rate. In other words, for people who've already fallen, there is a slight reduction in the number of falls, about 23%. And the RR stands for relative risk. So if your relative risk is below 1, then you have an effective intervention, and 1 is essentially something which isn't any better than doing nothing. No difference in the number of people, however, who experienced 1 or more falls. So there was no change in the risk. So a multifactorial intervention is not particularly beneficial for those who are a lower risk and you're just trying to prevent a future fall. There is, however, some evidence that fall-related fractures are reduced with a multifactorial intervention. So essentially what we're saying here is that multifactorial interventions should be reserved for those at highest risk, those that are falling most, and the frailer. The same review also looked at multi-component interventions. These are ones which there are 2 or 3 interventions routinely delivered to everybody. And it does vary a little bit between studies. And some of these studies, for example, have vision, some have foot health, some have continence. They all have strength and balance programs within them, and they all have medication reviews. But the other components change slightly. But essentially here, it's not individualised completely to the individual. They just receive all 2, 3 or 4 interventions. So these ones do reduce the rate at which people fall. There is some reduction in the number of people who experience recurrent falls, but no particular difference in fractures or hospital admissions. So essentially what we're saying is multi-component are also better for the very the frailer, more people who are having more falls. If you look at a systematic review by Deandra, who looked at multiple studies, again there were about 40 studies in this particular review, which had all considered different risk factors. And this is a meta-analysis of all the risk factors that are important in falls prevention. And you can see the top of that list is history of falls. And so we know if someone has already started falling, they're going to continue. But nearly all of the others have either a relationship with gait or balance or a specific neurological disease. And therefore the most important thing here is to improve strength and balance and reduce fear, because if you're fearful, you avoid activity and you avoid strength and balance, and therefore it gets worse. And interestingly, although this is hot off the press because it's not actually published yet, there's been a recent update in the Cochrane Review looking at exercise and falls prevention. And interestingly, exercise as a standalone intervention, not with any of the others, just exercise on its own, strength and balance exercise, reduces both falls risk, falls rate, reduces fractures, reduces hospital admissions and medical attention, and improves quality of life. So exercise should be the key component of any falls prevention programme, irrespective actually of whether that person needs or has poor strength and balance. What we see in these exercise interventions for this systematic review is that this is across the whole range of people at lower risk and people at higher risk. Exercise is by far better than a multifactorial intervention. I would like at this point to point out that as a PSI, it is your role to ensure that if there are risk factors which appear to be affecting a person's movement, it might be their vision, their feet or their continence, for example, then there should be a referral on so that those other components that might be affecting falls risk are also considered. Okay, what we see about the systematic reviews on exercise and falls prevention by Kathy Sherrington is that she pulled out within all those exercise programs that it was the dose and the delivery of the exercise that made a difference. So not all exercise programs have the same results. This is important. Zumba does not reduce falls, neither does kettlebells. What does reduce falls are things such as FaME. What we know is there needs to be a progressive high challenge to balance. We know that 3 hours a week of strength and balance training have greater falls prevention effects than a lower time period. Interestingly, some of those studies are once a week class, twice a week at home, some are fully home-based and some are fully class-based. So it really doesn't matter how it's delivered as long as the person does about 3 hours or leading up to 3 hours a week of falls prevention exercise. It doesn't seem to work on its own in care settings amongst stroke survivors or people who've recently been discharged from hospital. So when there's a key health element in there, or very frail older people, it does need to be a multifactorial intervention as opposed to just exercise. But we do know that evidence for falls prevention with people with Parkinson's, people with dementia, and that sort of thing, there are some studies which have shown improvements, but we perhaps need to have a few more to be certain. Now, many of you will not have seen a forest plot before, but I just wanted to introduce you to this because it's really got some important messages. The first thing to note on the left is a whole, and I'm not expecting you to read it, is a whole series of names with years. These are different studies, and FaME, the study for FaME, is in there under Skelton, 2005. On the right is the effect size of each of those studies. So these are all exercise studies with fallers. Right down the middle, you'll see a line with a 1. And anything that is towards the left of that line, so towards the name of the studies, means that there was a good effect of the exercise on falls. So it reduced falls. And anything to the right actually means that we're better not doing it, because by not doing that exercise program, you'd have had less falls. So what we're really trying to get across is there is a range of effect here. If you take all of those interventions, all of those exercise interventions into account, there is a reduction in falls. So if you count all the people in it, put all of those into a big box, shake it about, you get a 17% reduction in falls. But it hides a multitude of sins, as you can see from the next slide. So the ones I've highlighted are ones where the risk of falls increased with that particular exercise program. Some of these are brisk walking programs, and this is important because if somebody has started to get frail and avoid activity, they get very tired because they're deconditioned. So if you send them out brisk walking, they stop lifting their feet very high and they trip over everything. And this is really important because it also means in an exercise session, if they get tired, they won't lift their feet and they're more likely to fall. Also, some of those studies are general physical activity interventions where there wasn't supervision or support with the individual. They didn't focus on strength or balance. So they just increased the risk, exposure to risk, by getting them to do more, but weren't doing specific strength and balance programs. So it's really important to know that not all exercise works. And if you filter and reduce down the effectiveness of FaME, it won't work either. So the fidelity to the way that FaME is delivered is important. The other thing we learned from this review is that the benefits are lost as soon as the person stops doing the programme. There's a little bit of leeway. So, for example, FaME has been shown up to a year later to still have a benefit of reduced falls, but then it goes. And so people decondition because they stop doing the exercise programme. So ongoing participation is important. The same way that if you don't carry on taking your drug, you'll lose the benefit of the drug. We know that falls prevention exercise targets the general community as well as the community dwellers with falls risk. In other words, it works both in people who haven't yet started falling as a prevention primary, and it also works in people who are falling. It's just a different type of exercise. It works whether it's delivered as a group or home-based programme, as long as they do it. It's all about adherence. And we need to be careful about brisk walking programs. Strength training hasn't always been included along with balance training, but those that have strength training seem to have better effects. And again, the importance that if there are other risk factors with that person that you can tell, they should be referred off to have those looked at as well. The other thing we pick up is that we need a dose of about 50 hours. These are in people who are falling already, so not your primary prevention but more your secondary prevention. We need to be really, really key that we keep people working at improving their strength and balance for a decent duration of time. So for any of you that are involved in any programs, because some people are spotters for classes or they're helpers in FaME classes or PSI classes, how close are you to actually achieving those recommendations, and what might increase effectiveness and adherence? We'll come to some of those issues in a minute. Okay, and moving on, just a little reminder of where the evidence base is for primary prevention. So that's someone who is perhaps deconditioning a bit but hasn't actually started regularly falling. And we know that Tai Chi has by far the strongest evidence base, mostly because there's been more research trials on that than any other type of exercise. But we know that for those with mild deficits of strength and balance, Tai Chi reduces fear of falling, it improves self-efficacy. If someone's already started falling, it doesn't have a good evidence base because it has to be adapted so much that you no longer get the full 3D slow strength and balance training. Quite often it's seated. And as soon as something's seated, it's no longer a falls prevention programme. We know that any activity such as dance or calisthenics, for example, anything that maintains or improves balance or might help reduce the risk of a future medical condition, then that will help reduce your risk of future falls. And there is a strong evidence base I'll go on to show you in FaME, in the primary prevention of falls as well. So we know from the Cochrane reviews and systematic reviews there are certain doses, components of fitness needed. We need strength, we need balance, we need 50 hours, we need highly challenging balance. But you're here to learn a specific programme, FaME. FaME to be delivered as a Postural Stability Instructor, and you'll also learn a bit about a Targo within this course as well. So what do we know about FaME? Where is the evidence base for FaME? Why does it work, or how does it work, and who with? So for both the Targo and FaME, there's strong evidence for secondary falls prevention. In other words, people at high risk. So in the original Targo programs, they were generally frailer older adults living at home, that required sometimes walking aids around the home and were avoiding activity. This programme originally was 1 year long, 3 times a week. They were asked to do some home-based exercise, but over the course of the year they had 6 home visits, plenty of telephone support in between. It's been repeated more recently with a 6-month programme, 3 times a week, once a week in a group, twice a week at home. And we know that if it's run in a group, then the effects on strength and balance are much quicker, and the benefits much quicker. FaME, the original FaME programme was a 9-month programme, 3 times a week, once a week in a group, twice a week at home. It included floor work and is the programme you're essentially learning on this course. Interestingly, this has not only been shown to reduce falls, but also increase habitual physical activity, give people the skills to get up off the floor and therefore avoid long lies, and giving them coping strategies. And it's one of the few studies to have shown that people are less likely to move into a care home and not to change their residence. So the original FaME study was quite a long time ago. It was published in 2005, but the original study actually was at the end of the 1990s. This was 80 women aged 65 plus who'd had at least 3 falls in the previous year, and there's a photograph of some of them. There was a randomised control trial. So half of those women were put into a control group where they did nothing for the 9-month period, and half were put into the exercise groups, which were run across London. No exercise group had more than 8 people, and the instructors were all trained in the FaME programme. This was a seminal programme of falls prevention because it reduced their falls risk by half. So they were, even though they'd had 3 or more falls in the previous year, they were half as likely to have that many falls in the future. And in fact, even though we are some 20 odd years after now, the programme was run, I'm still in touch with some of those fallers, which is quite amazing because the general prognosis for somebody falling 3 or more times in a year is not good, normally hip fractures and hospitalisation and consequent death. FaME was then repeated in another randomised controlled trial called PROACT, where actually there were 3 arms to that study. So they were randomly put either into a FaME group programme, a Targo home-based programme, or usual care, which was just to receive a leaflet on falls prevention. As you can see from here, much bigger. We had 1,256 people in the study. They were not at high risk of falls. They were sedentary people recruited through general practice. And we followed them up for 12 months and 24 months after the intervention finished. So it's a very long follow-up compared to most research studies on falls. Interestingly, the primary outcome was actually habitual physical activity, and the secondary outcome was falls and injury. And if you look to the right, FaME increased moderate to vigorous physical activity by 15 minutes a day in the intervention group at 12 months post-intervention. So 12 months after the 6-month programme had finished, they were still doing 15 minutes a day more moderate to vigorous physical activity than they had been prior to the intervention starting. Otago had no effect on moderate to vigorous physical activity at all. However, by 24 months after, so 2 years after the intervention finished, there was no improved effect. They'd gone back to baseline, basically, because they'd stopped doing the exercise. FaME reduced falls. Interestingly, to not quite the same extent in the frequent fallers from the original study, but still a 26% reduction in falls, which is amazing considering how few fallers there were at the beginning of the study. So essentially it was stopping people becoming fallers. Again, at 24 months the effect had gone. And interestingly, in this particular group of people, so remember these are not high risk fallers, they're sedentary over 65s recruited from general practice, Otago had no effect at all. It didn't reduce falls. So again, it reminds you that Otago really has a better evidence base for the frailer older, not for your person that's going to walk into your gym. A couple of things to note in terms of evidence base for FaME wider than that. There's been a number of papers looking at FaME in people with Parkinson's disease. And an economic evaluation, it's viable evaluation for that. We know that there's good reductions in fear of falling as well. So it has a strong evidence base in people with Parkinson's as well. And more recently, we've done some work with people with visual impairment, those that may well be reported as blind in the community. The only thing we saw to be different with this group is that essentially you just need to be much more visual in your description, not in your delivery of an exercise. So your demonstrations are less important, but your verbal skills are vital. Touch is used much more often, a lot more correction needed because they don't often know that their body's not in the right position. And their class management skills are vital because there's a lot more chance of a domino effect and clashing because people don't necessarily know there's somebody right next to them. It's very important to ask about improvements and share that with the group because they don't see them. And interestingly, those with visual impairment often have multiple comorbidities, especially hearing. And if they've got dual sensory loss, it becomes very difficult to include them in a general class. But what we have found is that otherwise, most people, even people with quite severe macular degeneration or glaucoma, can quite happily come into a normal FaME program. They just need to be seated in the right place, be able to hear you, and your description skills need to be good. We also found that the family and carers of those with vision impairment are just as deconditioned and frail and benefited considerably from coming into the group with their spouse. But we know there's a very wide range of abilities and needs with the people that are going to come into our groups. On the whole, the top part of this diagram is that exercise has very positive effects on falls risk factors and certainly can reduce falls. However, the area circled in red is important. If someone doesn't do the exercise with good technique, if they get very tired, if they push themselves out of their centre of mass or their base of support greater than they can actually correct themselves, and of course they're more likely to trip over mats and things that are left on the floor. So you have to be very careful in this particular group that you are making sure you're observing, correcting, and making sure they're safe in the environment in which you're taking the sessions. You will also have some people who are frailer and seated for some of the exercises, and some people who are really fit and you have to really push in the same class. And that's where individualising your delivery is so important, and your skill set that you should learn on this programme is vital. Your ability to have somebody seated, someone standing, and perhaps somebody on the floor doing the same essential exercise but tailored to their different needs, so that everybody in that room receives a challenge of balance that's important to them. Because otherwise you're not going to get a reduction in falls. It's really, really important to individualise your delivery. This is not a class that you stand in front and get everybody to do the same thing. You have to have very different skills, and that's something you'll learn, I hope, on this course. So on this course, we spend a bit of time talking about specific forms of exercise that perhaps you want to avoid. So repetitive, sustained, repeated, or with weight end range forward flexion should be avoided or modified. And it's really important, again, to remind you that technique is vital, and your ability to see and correct someone's technique and correctly put that across so as not to annoy them, but to ensure they do something with the best possible posture will make a huge difference. Obviously, your foremost worry is going to be that someone's going to fall in your class. This is a class of falls prevention, and that's why it's so vital to do a risk assessment, to do your assessment of their ability and their balance skill at the start, and perhaps something that we had to do with the original FaME programme is consider hip protectors for those with osteoporosis or your frequent fallers. The original FaME programme, we weren't allowed to run it without everybody wearing hip protectors. Ethics wouldn't let us run the study otherwise. But more importantly, hip protectors can reduce fear. So if someone's really fearful and therefore not moving in their normal ability or capability, hip protectors can make quite a big difference to them. Okay, I'm just going to finish off on the importance of return on investment. So what we know is that Public Health England have been publishing a number of documents last year, which essentially were just reminding commissioners of falls studies how important it was to use an evidence-based programme. So in other words, not just to take on a provider who says, oh yes, my Zumba class reduces falls. It's really important that we are dealing with a clinical issue here. Falls prevention is a clinical issue, and therefore they should be using cost-effective interventions such as FaME and Otargo. I've done a webinar which you can get hold of on the LLT website for free, which goes into a lot more depth, and if you've got an hour and a half to spare, you can go and have a listen to that. But essentially, these two interventions that are in this Public Health England document, FaME and Otargo, are only cost effective if they're delivered with fidelity. And I'll go into a little bit more depth about that. But in other words, you could water down the FaME programme or the Otargo, or adapt it to such an extent that it no longer is FaME or Otargo, even if you call it that, and essentially it won't work. It'll no longer be cost effective. But more importantly, it won't reduce falls. And that's the whole point that people are coming on these programmes. So it's really, really important that people get fidelity. Just a couple of comments on cost effectiveness and return on investment. So cost effectiveness is essentially value for money. So how much does it cost to deliver a specific intervention to a population compared to doing nothing at all? Is one way of delivering it better than another? So for example, if you put Otargo against FaME, which one is more cost effective? Well, very much that depends on your population group. But interestingly, Public Health England basically say they're as cost effective as each other. This is important because, for example, a long time ago, there was some discussion by the government to have breast screening to pick up breast cancer early. And when they did a cost effectiveness analysis, they found out it wouldn't be cost effective. In other words, the cost to roll out breast screening at a younger age across the whole population would be prohibitive compared to the number of people that would be picked up early, and therefore it wasn't cost effective to do it. So there's a lot of controversy about cost effectiveness. However, in the falls prevention world, there's not much controversy. We know what is cost effective, and I'll come to that a little bit later. Then there's a return on investment. This is the ratio between the net profit and the cost of investment in delivering the intervention. In other words, if I set up an exercise program, I pay my instructors, I hire my venue, I buy my equipment, I do all the advertising to get people in, I set up referral pathways. What's the cost of doing that compared to the number of falls or fractures or other health issues that I might stop by people coming into that program? Sometimes it doesn't matter, as long as they're even, so it costs as much to deliver as you save, that's still a good thing, because let's face it, you're saving some hip fractures and some major issues to people's health. However, it always is nice for a commissioner to see something has a good return on investment. In other words, in the long run, you'll save money by putting into these particular interventions. It's important to say that these are only cost effective and there's only a return on investment if they are delivered with fidelity to the original interventions. And that's where it can unfortunately all go a bit wrong. To give you an idea of how cost effectiveness can change depending on your population group or how you deliver it or how long. If you look at the Public Health England tool, FaME has a financial return on investment of £1.04 for every pound that you save. If you take into account quality of life, then essentially you are having a cost benefit of £2.40 for every pound delivered. So it's not bad. You're getting some societal profit back, if you like. If you take the original FaME study, so on the far right of this slide, with your very high risk fallers, 3 or more falls in the previous year, you make sure you have very small group sizes, you do a lot of progressive work, then we're now looking at £5.50 return on every pound spent. If you look at the middle column, that's the PROACT study where sedentary older adults were recruited from GP practices, then essentially you're looking at about £3.30 return on every pound spent on your service. And that's not taking into account more people meeting the physical activities, less chance of long lies, reduced fear of falling. That's just taking your falls rate into consideration. But all of these cost effectiveness amounts are based on very important fidelity points. Each individual in that programme gets a 1-hour initial assessment by a postural stability instructor to learn their balance skills, to go through their functional grid, to have a conversation with them about their health, about how they're functionally able to move about, whether there's any other issues that have to be taken into consideration within the group, whether they need specific support around home-based exercise, your motivational interviewing in effect. It is costed for 6 months of delivery, 1 hour a week in a class, and of course people are expected to do their home exercise as well. Maximum of 15 people in a group, so not as I've seen out there in the real life where commissioners stuff 30 to 40 people in a group, and at that point you get no FaME delivery anymore. It might as well be a Zumba class. You're not going to reduce falls. It has to be delivered by a PSI who knows the evidence base and the evidence-based exercise. It accounts also for staff training, travel time, community hire, hall hire and equipment, etc. However, this is what we generally see in practice. Many times I've gone into a falls prevention class and it's seated. It's no longer a falls prevention class. There are certain aspects that need to be seated, so strength work is often done seated to isolate specific muscle groups or to make sure someone's not wobbly. But if more than half of the class is seated, it's no longer a falls prevention class. Quite often the average duration is 8 weeks or 12 weeks, so they're getting a completely ineffective dose. And there's very little, if no, strength progression. I don't know how many times I've watched classes where everybody has a yellow TheraBand. Why not? You might as well not bother. Just put it in the bin. Essentially, you need proper TheraBand progression. And finally, the amount of FaME classes where they don't do floor work, either because they haven't got mats, they don't have a hoist nearby, there's a health and safety policy they don't like, they've got somebody with COPD. They'll find every possible reason for not doing it. But floor work was a key part of FaME. It reduces fear, it improves confidence. It actually causes a lot of laughter in the group once people are down, and it was a key part. So all this cutting corners, cherry picking and risk aversion means essentially it's no longer a FaME programme. So they shouldn't be calling it that. Interestingly, FaME is the only intervention that's actually given falls rates throughout its whole delivery. And if you speak to many other authors of falls prevention programmes, they have all seen this, but they don't necessarily report it. When people first start exercising, if they've not been exercising for a while and they've been fearful, they actually can increase the number of falls they have because their confidence goes up quicker than their ability to correct a trip. And so in the FaME intervention, during the 9 months, there was a slight increased risk, about 19%, but they were far less likely to have an injurious fall. So they fell better from straight away. It was only in the year following there was this drastic reduction. In other words, back to there's a set dose before there is a real strong effect on falls prevention. And if we increase people's confidence before we give them the skills to stay upright, we could actually be making them more at risk. So it's really vital because most services will not deliver a 50-hour intervention. And so it's most important that we transition people on to future exercise opportunities, whether that be along to the local dance class or Zumba class, if they have good enough balance to do that. But most importantly, we do need to facilitate that moving on and people understanding that, like a drug, it doesn't just stop. It doesn't just carry on working when you stop doing it. You have to carry on doing strength and balance exercise to maintain the benefit. So here's just a couple of slides of some service evaluations. These are not pure research. There are no control group. There probably is bias in here. But these are where local groups have had to prove themselves to their funders that it's worth carrying on with their delivery. So this is the Steady Steps programme in Edinburgh, delivered by PSIs. And essentially you can see that they have used a variety of measures. On the right hand side, they've got an improvement in balance confidence, that's ConfBal that you'll do within your assessments of a PSI. improvements in physical function, particularly timed up and go and chair rise, not experienced a subsequent fall, so they followed up for a fairly short period but shown that 75% of that group didn't go on to have another fall, and have remained active post-programme, means they've managed to move them into other exercise interventions in the community. So they've transitioned them safely onto other programmes. At the moment, there's a number of bits of research going on, including an implementation toolkit for commissioners for the FaME programme. That should support you defending yourself when you go back out with this qualification. You may well have been sent on this course by a funder, who are then going to just ask you to set up classes and shove as many people into them as possible, possibly not even the right sort of people, and you're going to end up having a bit of a nightmare if you're not careful. So when this toolkit comes out, we will share this with you. But again, a reminder, it's really important for you to be able to individualise your programme. You shouldn't have too many people in your group, and you should be progressive with each of them. So for some people, they may still be on a yellow band. For others, they might need to be on a grey band or a black one. For some, they might well be able to do toe walks backwards. With others, they're still holding onto the back of the chair doing heel rises. So in the same class, you need to be able to individualise. The good thing about this is it hopefully will inform commissioners of future delivery of FaME to not cut corners, be risk averse and cherry pick the evidence base. So thank you for taking a listen with me. I'm going to ask you to do two key things to bring with you for day 2, just for us to discuss within the group. I want you to write down 2 key evidence points that describe why FaME is an evidence-based programme. So either name me some research trials or give me some key points on why FaME is evidence-based. Why is FaME not kettlebells or Zumba or body pump? Write down 3 key fidelity points to FaME delivery that are vital for your commissioners to actually get a return on their investment. What's going to make it work? You need to become a champion of evidence-based practice. You need to defend your groups, because believe me, over time they'll get bigger and bigger as they try and get more people into those groups without actually just getting another class up and running. You need to be able to prove your knowledge and understand the evidence base so that you can argue back with bosses about the sizes of your classes, and make sure you get the right equipment and make sure you're allowed to do the key parts such as floor-based skills. So hopefully you'll bring those with you on day 2, and we can discuss that in a small task within the groups about the importance of the evidence base for FaME.